Hello, hello. Hopefully everyone who is attending today's webinar is now able to see the panelists and planners here in front of you, and we're going to get started with today's webinar. So thank you for joining us for the fourth and final webinar in Health Promotion Ontario and Ontario Public Health Association's November series on health promotion in a global pandemic. Today we're joined by four great speakers who will be sharing their perspectives on inequities that are arising in the pandemic and what we can do about them. I'll say more about our speakers shortly, but for now, by way of introduction, I think it's worth noting that we have four unique health promotion perspectives, including Zoe Dodd, who's a community activist, Kim Perota, who leads an environmental health nonprofit, Jennifer Rayner, who helps manage the community health sector across Ontario, and Ahmed Bayoumi, a clinician scientist. And my name's Ketan Shankardas, and I'm an associate professor at Wilfrid Laurier University, and I'll be moderating today's webinar. I'm going to get my slides going. So, okay. So first, let me tell you a little bit about Health Promotion Ontario. Health Promotion Ontario is the voice of those in the profession of health promotion across Ontario. We seek to advance the critical importance of health promotion and its practice through professional development opportunities, membership, member communication, and advocacy. We're a constituent society of OPHA, and we've been active since 1987, just after the Ottawa Charter was created. Our members represent a variety of sectors and spheres, including people working in public health units, community health centers, universities, and other health-oriented organizations. HPO is also the founding chapter of Health Promotion Canada. And if you're interested in membership, this year, acknowledging all the difficulties everyone is going through with the pandemic, we have a very affordable student member rate of $25, and other members can join for $60. So if you're interested in joining Health Promotion Ontario, you can follow the link on the screen, and I think we can also put that in the chat if you want something more clickable. So we are out there trying to advocate for strong health promotion approaches in this province and find ways to better serve health promoters working in the field. And this is an example and an opinion piece that we recently published in the Hamilton Spectator, inspired by our second webinar of this series on the shadow pandemic, and written by two of our executive members, Benjamin Rempel and Jeanette Leroux. And there's also going to be another opinion piece tied to today's theme of inequities during the pandemic, which will be published imminently, featuring an interview with Dr. Ahmed Bayoumi, who's on today's webinar, and we'll share a link to that opinion piece with all of you on this webinar today when that's available. A couple of housekeeping notes. So we have four speakers today, and we're going to have about 8 minutes for each speaker. And then we'll have time at the end for questions to discuss across all of the speakers. So those of you in the audience, you are muted automatically, but we welcome your input through questions for panelists in the Q&A widget, which is at the bottom of your Zoom platform usually, or it might be at the very top. So please use that widget for any of your questions. Given time constraints, we'll be holding all the questions until the end of all the speakers, and we'll then have to select from your questions to use to moderate the discussion. Unfortunately, we don't have time to get through everyone's questions during these webinars. So if you're a panelist, you're welcome to keep an eye on the Q&A and feel free to respond to audience questions there. And if we don't end up addressing your question at all and you're in the audience, I don't think our panelists would mind receiving an email after today's webinar if you want to ask your question to them directly. Finally, all of our webinars are being recorded and will be available on YouTube and on the HPO website starting next week, hopefully. And we'll send a reminder out to all attendees of these webinars that those recordings are available in case you wanted to watch them again or share them with any colleagues that you think might be interested. Okay, so without further ado, let's hear from our first panelist. I'd like to introduce you to Zoe Dodd, who's going to talk to us about COVID-19 and the worsening overdose crisis in Ontario. Zoe's a community activist working with the South Riverdale Community Health Centre and the Toronto Overdose Prevention Society. The focus of her work is on HIV/AIDS and Hep C, poverty and harm reduction. She co-founded the Toronto Community Hep C program, and in 2018 she received the Casey Award for leadership in the fields of HIV/AIDS and social justice. And so Zoe, I'm going to stop sharing my slides and I'm going to invite you to share with us your perspective on this topic.
Thank you so much. I'm not going to be sharing slides today. I'm just going to be talking, and I just first wanted to introduce myself and say I work at South Riverdale Community Health Centre. Thank you, Ketan, for that. I coordinate the hepatitis C program there, and I also, like since COVID started, have been helping with the Anishinaabe Health's COVID testing mobile. I go out with my coworker Les Harper many times a week to encampments, to drop-ins, to other places, and we're there, to engage with the community and to help if there's an overdose. And there have been overdoses when we have been out with them doing COVID testing. So I just want to first off start by saying, to understand the overdose crisis, we do have to understand sort of the complexities of it all. And so I'm going to talk a little bit about that as well as what's been happening currently. So I first off want to start by saying that the last 8 months have been really devastating. I feel absolutely terrible. It's like we are in this crisis and only we can see it. Only we know the toll it's actually having. And you feel alone trying your best to shoulder a crisis without the resources or coordination or funding a crisis should have. And so, yes, I work in Hep C, but also as part of the hepatitis C program's mandate, we started doing overdose response about 2010 and doing some focus around overdose because a lot of people in our Hep C program were dying. What a public health emergency would warrant would be coordination, communication, resources, and that you wouldn't feel abandoned in a response. Because that if you were trying your hardest to respond, if we weren't doing that, more people would be dead because government at all levels have failed to address the overdose crisis properly. So 50 to 80 people are dying a week of overdose in Ontario now. That's about 9 people a day. That's 1 in 5 deaths that are happening here in Toronto. People are dying in their homes, in parks, shelters, doorways, public toilets. We fought so hard to have the inclusion of people who use drugs in leadership roles and employment, responding to the overdose crisis and helping to expand harm reduction, only to see many of the people who led the way, who have worked so hard supporting others, also die. When COVID hit, we didn't work from home. The majority of my colleagues never worked from home. They stepped up. They leaned into the pandemic because we know how to lean into a crisis. We all ramped up street outreach. We volunteered to be on the street when people were using outside and overdosing, when Public Health The Works supervised consumption service that saw 3,000 visits a month, closed for over 4 weeks and reopened by appointment only. People volunteered their time while everything was in lockdown to be out there assisting if needed. On outreach, we responded to overdoses almost every time we went out. The other 8 supervised consumption and overdose prevention sites in the city adjusted to COVID and infection protocols, having to reduce capacity but kept their doors open. I think we have all seen dead bodies now, found people dead on the streets, run to respond, only to find them blue and without a pulse. The drug supply got more toxic, but it's been actually like this, chock full of benzos for over a year now. The drug laws and the continuous drug war effects helped to usher in synthetic drugs that could be snuck easily over borders, bought off the internet, manufactured here. There is no one in charge of the overdose crisis at any level of government. There's no collaborative table that meets regularly to discuss how to tackle this crisis. In 2016, Dr. David Williams, our Chief Medical Officer of Health, was appointed the head of the overdose crisis. Despite an increased deaths related to fentanyl, he said publicly at the National Opioid Summit that same year, I asked 6 months ago, I asked 4 months ago, why we're not seeing it, bootleg fentanyls. We have to ask ourselves about that. What does that tell you? What did that tell us at that time? Those that were responding, that our public health leaders were deeply out of touch with the reality of the ever-growing crisis and weren't going to help us. The province's response was to focus on overprescribing, but that wasn't what was causing the overdoses and deaths. It wasn't prescription drugs, it was bootleg fentanyl and carfentanil. In 2017, after much advocacy and pressure, the province created the Overdose Task Force. This was co-chaired by the former CEO of South Riverdale Community Health Center and Dr. Williams. It was a multi-sectoral table that included the voices of people who use drugs and pain patients. Despite the good work it was doing, that table has not met since Ford took office. And despite the recent report put out by Public Health Ontario and the Chief Coroner's Office, it is estimated that nearly 2,300 people will die this year alone. And that we learned after the release of this report through a FOI made by the NDP regarding communication with the CMOH, the Minister of Health, the Minister of Addictions and Mental Health, the Chief Coroner's Office, and the Premier, was that they are not communicating. There have been no email communications between them and the overdose crisis, about the overdose crisis this year. That same week, we learned that there were over 600 unclaimed people this year who were buried without their family and friends knowing that they are dead. Many of these people are homeless and people who use drugs. Back in May, with the ever-increasing drug alerts and increasing deaths, the CMOH was back in the media talking about Vancouver and BC. Despite our numbers of overdoses and deaths being greater, they have big challenges there, he says. We don't actually have that. He called the overdoses in Vancouver one of a kind, that we had a much larger and wider bulk of municipalities and that it was different here, that the street drugs moving through Ontario were different, and that we needed to be informed, that we needed plans or strategies carefully in a timely way if we were going to go forward. This is what he was saying in May. And he said, adding that more could be done to address this issue. But we are informed. We have the data, we have research, we have drug checking, we have coroner reports, but what we don't have is leadership from government, from our public health leaders with coordinated tables. And we don't, with coordinated tables with communication and with resources. Expansion of overdose prevention pretty much ground to a halt after Ford became elected. The overdose prevention site model that many of us created as an emergency model was almost completely abolished in this province, although 2 sites in Toronto still operate as such, as their funding was cut by the government. But municipalities are desperate to open them, and we need them where people are overdosing and dying, in shelters, shelter hotels, public housing, and so on. There's also infighting amongst community people and addiction specialists on how to respond, in particular around the role of safer supply and the prescribing of opiates so people don't die. We have a drug treatment system that lacks evidence, is archaic, and doesn't meet the needs of diverse populations. This system also needs to change to be responsive, evidence-based, regulated, and actually a part of our healthcare system. The federal government has given some funding for safer supply projects to a few community organizations, including South Riverdale Community Health Center, but this funding is not enough and only lasts until March 31st. Meanwhile, we're throwing cups of water at a raging fire, running in different directions, begging for an emergency response. We have paramedic data, but knowing where and when majority of overdoses are occurring cannot be shared due to privacy reasons, so we don't sit at tables strategizing where our efforts should be best implemented. Our overdose response interventions are not accurate or the same. We have been disagreeing for over a decade on how to respond to overdoses, and so now we have people confused by what they have learned. Before naloxone was legal, you didn't need a prescription for it. A few of us were distributing it, having got it from the US, and were teaching overdose response. When the city's program was created, they chose chest compressions over rescue breathing, and we didn't see eye to eye. We removed thousands of instructions when the Ministry of Health created their instructions, chest compressions, then naloxone. They were wrong. So again, we disagreed. This is incredibly problematic that there is no standardized education and continuous updates in overdose response, as the drugs change and the responses change too. Coordination, communication can help solve these issues. I am witnessing a level of human suffering I have never seen before. Over 1,000 people in tents and parks, people dying on the streets, overdoses increased. People are losing hope and feeling defeated. Over 5 years, the overdose crisis has raged on, and these last 8 months, compounded with COVID, the housing disaster, grief, and trauma, is unbearable. Our need for support for the grief and trauma of loss goes unrecognized. Real lack of supports for witnessing people almost die and making sure they survive is not a priority. I never personally saw myself administering naloxone, administering oxygen, yanking people blue from toilets, saving my own friends' lives as a role I would have, and I have done it hundreds of times. I never wanted to be a nurse or a medic. I facilitated groups for over 15 years with people who use drugs, helped them get cured of their Hep C, and supporting them therapeutically. That was harm reduction, justice work, therapeutic work. Now it's emergency work downloaded onto the shoulders of people who are being traumatized continuously and trying their best to keep people alive. Yesterday in Vancouver, their city council unanimously passed a motion for decriminalization. Perhaps this will have a domino effect in this country and lead to an end of criminalization and an opportunity to create a real model of decriminalization that works, not one that penalizes people for what they put in their bodies, and perhaps a reallocation of funding. It will take decades for people to heal from the trauma of loss, from the over 20,000 people that will have died these last 5 years and the years before. Stigmatized, disenfranchised deaths, sudden deaths are hard to heal from. The trauma of all this loss of harm reduction leaders, family deaths, family members, friends, community will have ripple lasting effects. The root causes of habitual substance use come from trauma, poverty, unemployment, the effects of colonization, racism, homophobia, transphobia, criminalization, deaths, and the list goes on. COVID has laid bare the massive inequities in this country. It has exposed the problems with our system. It has also made people think about what that system transformation can look like. And if we're going to stop the overdose crisis and actually see an end in sight to it, we need to transform it. Because we are not in this together, and we have never been. Thank you.
Thank you, Zoe. I want to acknowledge the weight of what you shared with us, and thank you for your ongoing service that you're doing. That wasn't always easy to hear, but I think you've done a really great job of identifying a clear objective for health promoters in Ontario. And maybe we can talk a little bit more about that later. Let's move on to our second speaker now. I'd like to welcome Kim Parada. Kim has a master's degree in health science and 35 years of experience doing research, policy analysis, and health promotion on environmental and built environment issues. Kim's going to talk to us today about the double impact of climate change and COVID-19 on disadvantaged communities. And she brings a wealth of experience as the executive director of CHASE, Creating Healthy and Sustainable Environments. And she is also the past executive director of CAPE, the Canadian Associations of Physicians for the Environment. So she has a lot of experience thinking about the role of climate change and how it's kind of intermingled with COVID-19. Kim's foci include research, policy analysis, health promotion on environmental and built environment issues. And Kim, I'd like to welcome you to share with us now. Kim, you're muted, and so you should see the little mute microphone in the bottom left of your screen, perhaps. And
unmute myself. Okay, so you can hear me now? Okay, and share the screen. Okay. Okay, can you hear me or no? Oh my gosh.
Yes, we can hear you, Kim.
Oh, great. Thank you very much. Okay, that's great. Sorry about that, folks. Okay, so so I just want to, I'm going to kind of chat a little bit about climate change, COVID, and health inequities. And just want to provide a really quick overview of the climate change impacts that we're seeing in Canada, just to remind people what we've been seeing over the last few decades: more frequent and more intense heat waves, rainstorms, wildfires, floods, storm surges. We're seeing the spread of vector-borne diseases like Lyme disease across the country. We've got melting permafrost in the far north, and we've got increasing levels of smog and algal blooms, that kind of thing across the country. In terms of how this can affect the health of people in Canada, there's a very, very broad range of health impacts, from everything from injuries from trauma to hospital admissions and premature deaths from heat waves and air pollution, people being affected by power outages, damaged infrastructure that cuts them off from food and medical supplies for weeks at a time. Evacuations have been, over 500,000 people over the last few decades have actually been evacuated because of floods and wildfires. And this is associated with dislocation and financial losses and mental health impacts. And we've also got food insecurity. So I'm just saying them just so people can kind of keep in mind that we're talking about a very broad range of health risks when we're talking about climate change. The other thing we know about climate change is it amplifies the inequities and vulnerabilities in our society. So, for example, we know that older people, people with pre-existing health conditions, their young children are very sensitive to air pollution and to heat waves. So to the extent that climate change is increasing those events, these people will experience greater harm. We know that people in the Indigenous people and those who live in the north, who are more connected to the land and perhaps rely upon the land for their food supplies, that these people are being impacted by melting permafrost and unstable ice roads as they can no longer access food supplies that they've depended upon. We also know that people who live on low incomes, who are already at greater risk for poor health outcomes, have less control over their exposure to some of these events, like to heat waves and to floods and to wildfires, and they also have fewer resources for recovering from things like floods and evacuations and financial losses. We also know that these communities are more likely to be racialized. So just to kind of dive into a few of these examples, so with heat waves, we know that the number of extremely hot days is increasing very rapidly over the last few decades, and it will increase again, double or triple in the coming decades unless we get climate change under control. We know that heat waves can increase premature death, heat stroke, and we know that it aggravates cardiovascular and respiratory conditions. So what we have is an event that can actually stress the organs or the systems that are already being impacted by COVID. So it's quite possible. Yes?
Kim, I'm sorry to interrupt, but your slides are actually not being shared. So I'm just going to ask
really?
you to, yeah.
Oh my goodness, okay. Oh my goodness, okay. For the whole time?
Yeah, but you've been a very compelling speaker. I think we're following along well, but we'd love to see the slides too.
I'm really sorry about that. Oh my goodness. Okay, can you see them now?
Yes. And if you could just
start the slideshow.
If you could start the slideshow and then. Perfect.
Okay, so can you still see them?
We can.
Yeah, I'm really sorry, folks. I'm really sorry about that. Okay, so I'm just going to go back to see where I am here. So, talking about heat waves. So, we know that heat waves have increased. They've doubled or tripled the number of days. We know that they are going to increase. We know that they're impacting the same organs and systems that are impacted by COVID-19. And we know that low-income populations, for example, are less likely to have air conditioners. They're less likely to have air conditioners in their workplaces and their homes. They may have to work outdoors. In terms of wildfire smoke, in the last number of years, we've seen very intense and prolonged periods of wildfires, and we know that they're as well as evacuations that are threatening communities and dislocating people. We also know that they're producing extremely high levels of air pollution over huge areas. So with the in the fall, we had in California, we had those wildfires. They were actually producing very toxic levels of air pollution way up in Vancouver. We had air quality health index readings that were 10 plus, actually off the chart. So we know that we're going to see more people in the emergency rooms. We're going to see an increase in premature deaths associated with those very acute exposures. But again, we know that wildfire smoke aggravates cardiovascular and respiratory conditions, which are the same organs and systems, again, that are impacted by COVID. So it's quite likely that they are increasing the severity of the cases, or perhaps death rates from COVID. And again, low-income populations less likely to have access to air purifiers at home. They may have to work outdoors, so just having less control over their own exposure. Again, there's been a lot of research done on air pollution as it relates to COVID death rates. A number of studies have actually found that areas that have long-term exposure to higher levels of air pollution, to PM 2.5, is fine particulate matter, one of the indicator air pollutants that we use. We know that long-term exposure increases the risk of cardiovascular and respiratory diseases, and so these are the comorbidities that increase the risk of death rates from COVID. And so, and I'll just point out that we do know there's quite a bit of research that suggests that people in low-income populations are more likely to be exposed to higher levels of air pollution in terms of traffic-related air pollution or industrial air pollution. And again, some studies that were done around the world have actually found, they've actually estimated when they looked at air pollution levels around the world, they've estimated that 15% of the deaths that have happened from COVID, this is a global average, could actually be attributed to air pollution's impact. They've said that in certain areas of the world, like northeastern North America, it could be as high as 25% because there's higher levels of air pollution. So just mentioning that we've seen with COVID that it's threatening some of the climate solutions that we really want to see. So public transit, getting people out of their own vehicles and into public transit, this is something that would cut greenhouse gases. It would reduce air pollution. It would increase social equity. And yet our transit authorities have seen ridership plummet during COVID. Transit agencies are losing their fares, they're losing their funding, and some of them are having to cut services and maybe even at risk of going out of business. And so a number of us are advocating to governments saying that we really need them to pick up the funding for transit authorities, and not only to maintain service, but they should be increasing service to low-income neighborhoods, to people who are providing essential services to reduce overcrowding and to protect them from COVID. That we also need dedicated bus lanes to increase the efficiency and the speed of that service. And then on the other side, what we have seen is that COVID has actually accelerated some climate solutions by really helping us to step up telecommuting and teleconferencing. We've seen cities building up bike lanes and expanding space for pedestrians, and really recognizing the need for more parks and green space. And so this is all really good, and we want to really build on this now that citizens have had that experience, but we really need to ensure that we make this infrastructure and these services available to low-income neighborhoods. Thank you. I'm sorry about that.
Thank you, Kim. Very interesting to see all of the ways that these two issues are intermixed. And like with Zoe's topic, it seems like an issue that precedes the pandemic. And when the pandemic hits, all attention probably goes away, and as we focus on infection control, and I'm seeing a theme here, how do we get governments to not just throw everything aside and focus on infection control, but see the synergies at work here? So I'm now going to introduce our third speaker, Dr. Jennifer Rayner. And Kim, I'm just going to ask you to stop sharing your screen, and then I'll share mine. Great, thank you. And I can do that. Thanks. There we go. So Dr. Jennifer Rayner is the Director of Research and Evaluation at the Alliance for Healthier Communities, the AOHC. She's going to be talking to us today about the collection of race-based and socio-demographic data. Jennifer focuses mainly on using epidemiology and community health approaches to improving care for people facing barriers, and she's also an associate professor at the IHPME at the University of Toronto. And thank you so much for joining us today, Jennifer, and I'll invite you to start sharing your slides with us now.
Great, thank you. Okay, thanks. So I'll be talking a little bit about our role at the Alliance and how community-governed organizations really try to use the race-based data and sociodemographic data to try to respond in as equitable ways as possible as COVID-19 kind of ripped through our communities. So before I get started, I wanted to talk about the models of health and well-being at the Alliance. The circle on the left is the model of health and well-being that all Alliance members have endorsed and adopted, and this includes community health centers, nurse practitioner-led clinics, and community-governed family health teams. And the circle on the right is the holistic model of health and well-being, and this has been adopted by all of the Indigenous primary care organizations, including AHACs and Indigenous community health centers. So really all of these, it's a pretty fancy way to describe our roadmap or our North Star for service delivery, but they do include our values and attributes of care. And you'll notice things like comprehensiveness and social determinants of health and health promotion and prevention, and trying to approach everybody with an anti-oppressive lens, and the importance of trust and role of the community. I saw a question in the box about, how do community health centers balance advocacy? And Zoe I'm sure can answer this better than I can, but I think within our model, we know that we can't improve a person's health until systems change or communities are safer places to live. So I feel strongly that we just believe that this is part of our mandate and providing comprehensive community-governed primary health care. So there's a little reference there from a paper that I wrote just describing this model, but specific to this population, all of our data collection and our evaluation efforts can be mapped to these models. So if somebody asks me, why the heck do I have to collect this piece of data, I can directly point to one of these attributes or values to show why we collect it and why it's important. And often it's to ensure that we've got equity data, so we know we can understand our outcomes based on income, race, sexual orientation, or even understand factors such as loneliness or household composition. So within the first week of the pandemic, as a researcher, I was kind of grappling with what do I do? Like, if I could have gone out to a CHC and helped do anything, I wanted to help. But I'm in a provincial role, so what I did is I rolled up my sleeves and I started doing interviews with all of our members. And the goal wasn't to write a paper, which I ended up doing anyway, but I really wanted to identify concerns or figure out what was going on the front lines that people needed us to do as a provincial organization to help. What I heard during these calls were massive inequities were being talked about, barriers were being described, and I heard this in urban areas, rural areas, northern areas, remote areas. I think COVID hit us, it was a world already riddled with inequities, and what we were seeing is that all of these were being exacerbated and highlighted. And it was interesting in those first weeks because I think we were all just reeling and hearing this from our member centers who were dealing with this on the ground was pretty overwhelming. I can't even imagine what it was like for folks actually, working in these environments. And I think what we heard over and over again that was the pandemic was loudly revealing and continues to reveal how these structural injustices were cutting lives short of people who are subjected to systemic racism, poverty, and other structural barriers. And you'll probably remember, we tried so hard to get race and income data so we could figure out who was being impacted by COVID. And our chief medical officer's response to the request to collect this data was that, the crisis would be colorblind. Everyone was important. And we know, hopefully everybody on this call knows that when you don't have data, you often can be, a problem can be invisible. But at the Alliance, we collected this data. Remember, we collected race and income and household composition and housing status. So we were able to identify risk and act on this to make sure people had primary care. They had, we helped provide basic needs. And now we're trying to set up community testing sites. And I'm going to talk a little bit about that because we were able to use that data to proactively manage this. So what we first started doing was trying to identify folks who are potentially at greater risk. So many of us, many CHCs, use their electronic medical record that includes all of that demographic data that describes people, but also conditions that might have made people more or less at risk. They then gave these lists of just tangible lists to staff members to call. And equity data was used to highlight and bring to light people who might be experiencing barriers, or just identifying folks who might need food, or as we discussed, ongoing primary care. So during these calls, providers would check in with clients, they'd identify and address their needs. They tried to do this preemptively, as well as answer questions about COVID and also what was going on in their communities. And these calls really served as a real-time risk assessment. And if people were identified as vulnerable, so they were at risk of homelessness, social isolation, food insecurities, mental health, substance use, or they just needed to check in because they were living alone and they were feeling isolated, these calls continued on a weekly basis. And many of the health promotion staff at this point quickly redesigned their programs to make sure they were virtual. The other piece that was really important was we wanted to make sure people had ongoing primary care. And as Zoe said, many of our organizations couldn't close down. They couldn't work from home. Virtual care was a dream that didn't work for clients served within CHCs. Digital equity was highlighted over and over again. So people had phone drives, they got corporate donations, and they tried to reallocate their existing budgets to provide folks with phones and digital access for people who didn't have access anymore. They provided breakfast and lunch programs, they provided gift cards, they organized hampers for basic needs. So you name it, stuff was being identified with this data. I'm going to end on I think one of the most important things that our data is being used for right now, and that's really to identify areas at risk for COVID. We're identifying community testing sites or areas that are hotspots, and the government and the Ministry of Health and the public health organizations are beginning to understand the importance of this data. And what we're doing with this information is setting up community testing. This picture is folks at Black Creek Community Health Center, which have set up a testing site at the Jane Finch area, which has really been one of the areas most hard hit. And what we're doing is ensuring community members are meaningfully involved and have their voices heard. And this is so important to gain and keep trust. And it also, communities know their communities. So they've got innovative ideas and strengths and contributions that we're really trying to leverage. People are being paid an honorarium to really go out and reach residents who might be skeptical about testing, and they're able to reach people in all sorts of different ways of life. So we're hoping this is going to make a difference, and this is happening throughout the whole province in different ways. I know we're going to get to some of these things, but I couldn't end without just throwing a few thoughts. We've been collecting disaggregated client data for about 20 years now, and we need to make sure we use the data with appropriate governance and access. One piece of data is just one piece of data. I always think we need to combine that data to contextualize it. And people are more than just one piece of data, so we just need to reflect that. And always have action in mind. I think it's so important that we actually have a plan on how to action the data. And finally, I think we need to ensure equity is included in how we evaluate our progress. Quite quick run through of all we've been doing for the last 20 years using equity data, but I've left my email and I hopefully we'll have a bit of time to chat. So thank you.
Thank you, Jennifer. That was, again, very topical, and I really liked how you showed, whereas Zoe showed that in this time we need to be going out there and seeing where the need is and acting. I think you showed us an approach from a systems level that we can also be using data to show us where there's need and to act. And the common thread here is we need to be proactive if we want to make sure that existing inequities don't get worse during this difficult time. So thank you. So I'm going to move us on to our next speaker, our fourth and final speaker, Dr. Ahmed Bayoumi, who's a scientist at the MAP Center for Urban Health Solutions and a general internist and HIV physician at St. Michael's Hospital. He's going to be talking to us about a research study that he's helping to lead called the Marco study, and he'll tell us a little bit about findings to date from the Marco study. More generally, Ahmed focuses on the delivery of health services, particularly to people who use drugs, people living with HIV, and other marginalized populations. And he is the Foundation Baxter and Alma Ricard Chair in Inner City Health. And so welcome, Ahmed.
Thank you. Okay, then. So I'm going to talk about our study and really talk about what we've learned so far from the Marco study. As Caitlin said, I'm the co-principal investigator. I do want to acknowledge my other my co-principal investigator on the study, who is Michelle Firestone. So Marco really stands for marginalization and COVID-19. And it's a study that we started soon after the global pandemic was declared. And the goal is to evaluate programs that are affecting people who are experiencing marginalization during the pandemic and to provide guidance regarding how to optimize those responses. And we went into this project really trying to have a broad perspective. We ended up having a team of, I think we're now over 35 investigators, and those are both investigators from academic backgrounds as well as investigators in the community. And we're using a program evaluation framework, so really trying to identify programs that are particularly important for the health and well-being of people who are experiencing marginalization, and to provide guidance on what's working with those programs and how those programs could be improved. We're using multiple different methods. Each of our evaluations is grounded in both surveys and qualitative interviews. We are partnering with communities throughout the project, and we're really trying to focus on identifying solutions rather than just documenting problems. We have 8 evaluations that are currently underway. Some are just, a couple are just getting started. Most of them are about to start data collection. We have a range of different types of programs. Some are community-led. Some are focusing more on how those programs were administered. We have different types of questions, and we have a diverse set of populations that we are working with. And I'll refer you to our website if you want to see a full list of programs. I'm going to talk so much, not really about the programs themselves, but about some of the overarching lessons we've learned from Marco. And we are committed to an intersectional approach, and I'll say a little bit more about that as we go on. So how did we get to where we are right now? So we established a steering committee soon after we got started. That steering committee right now is only investigators. We have several times asked for community investigators if they would like to come on, but to date, nobody has done so. So unfortunately, that steering committee is only academic investigators. We do have a separate community committee, which I think is one of the reasons why we don't have community members on the steering committee. Again, if we were going backwards in time, I think we would structure this a bit differently, but that's how things have ended up now. Both of those committees help to select and prioritize programs, which I'll talk about in a bit more. We have now, each program evaluation has team leads. There are 2 or 3 leads for each of those programs, and each evaluation has at least 1 lead who is a community investigator. The evaluation teams have a comprehensive list of tasks and fairly tight timelines that we're trying to meet in order to be able to do our work rapidly. We, in each of the evaluations, has developed a logic model. We had online webinars, written resources to train our investigators in what a logic model is, what a theory of change is, and then we actually held logic model building sessions online as well. So I want to talk really about 4 things, and that's 4 areas where I think I've learned, and I think all Marco investigators have learned some things from trying to do this work in the midst of a pandemic and trying to do work fairly rapidly, and work that is committed to being in partnership with communities and at the same time addressing marginalization and addressing intersectionality. So I'm going to talk a little bit about COVID-19 and what that has meant for our work, about the priority setting exercise that I mentioned briefly before, about working with peer researchers in the context of COVID-19, but also more generally, and some thoughts about intersectionality. So this is a large project. We have many different dimensions to this project. We have 3 full-time research coordinators working on the project, and we've done all of this work remotely. We have yet to have a single face-to-face group meeting for the project. So this really is a project of our time, meaning of the pandemic times. We were lucky in a sense that the structures at our hospital where our research program is based established a protocol for rapid approval of COVID-related projects through the Research Ethics Board. So we were able to actually accomplish or to complete a lot of the administrative tasks fairly quickly. But there have been some challenges. I think many people experiencing fatigue from being on many different Zoom calls, and being online, of course, is not the same as being in person. But more specific challenges for Marco include making sure that everybody that we want to be involved in the process actually has access to the technology that allows them to be involved. Some of our community members, some of our peer workers, for example, don't have computers or they don't have internet access at home. So sometimes they join calls on the phone. Sometimes they join calls without video. And we have to be really conscious of how having different technologies enforces different hierarchies in terms of the ability to participate in discussions. It's also, I think there's some careful thinking that needs to be done about meeting structures and how easy it is to not include people in conversations over Zoom and how that differs from face-to-face conversations. So we've tried to do this and really have tried to ensure that some of the people with lived experience who are not very vocal in calls have real-time access to a research coordinator. So one of our research coordinators' job now is to support people with lived experience during Zoom calls to ensure that they have that access. And then, of course, the decision-making processes. We had our priority setting exercise. We included that as part of the research project. This was actually a challenge for some reviewers who really didn't like that we didn't have our priority set in advance. We had an open call for programs for people to submit programs. Anybody could submit a program. We had a web portal where people could enter those. We had 24 responses, and then we had a committee, a half-day meeting. We brought together our community committee and our steering committee to decide on which programs we would prioritize. We had a exercise beforehand to help us have at least an initial list, but then we really tried to do things as much as possible by consensus. Ultimately, we did have a vote on the final selection. But and really what we ended up selecting was more themes rather than particular programs, and there was a fair bit of work we had to do afterwards to actually identify programs. Interestingly, some of the academic investigators on the study gave us some feedback on the priority setting exercise, that they thought that there was a lot of information given and that we could go a bit faster. But some of the feedback from the community members was that it was just the right amount of information and the right pace. We are committed to engaging with peer researchers, involving peer researchers throughout this project. There have been challenges there too. There are different pay scales according to how peers are hired. Our hospital requires all peer researchers to have criminal records checks. There's different level of supports that are available for peer researchers, depending on which agency we're working with, which community partner. And we really want to think about research roles for the peers beyond just data collection, to include them in interpretation and knowledge translation and as co-authors on publications. And then we have a core commitment to intersectionality, and we're really still working through what this looks like. We have been clear from the beginning that although we have different evaluations, we're not a series of studies, we're not a series of sub-grants. We are a group of evaluations that inform each other and that really try and tackle some of the issues of intersectionality. And we also have documents and policies that try to focus our activities on multiple aspects of marginalization, including a publications committee that includes roles for peers. So just to wrap up, I think remote technologies offer some real challenges, as well as opportunities for working on community-based projects. We have been able, I think, to reach some people that otherwise wouldn't have been able to reach, but we do have to think about what barriers what structural barriers are reinforced by using fairly specific technologies. The community-based priority setting exercise that we did was, I think, novel, but it was feasible, it was entirely necessary, and ultimately very rewarding. Peer work is different from community engagement, which is a term that's often used, although I think there are better terms. But peer work really, there has, I think, been a surprisingly little amount published about what it actually means to do peer work effectively, and how we work with peers and how we support peers in that work. Moving towards intersectionality really requires a concerted effort. Working with communities is critical to success. And I didn't go into this, but I think it's interesting in our work that we found that communities often understand the sort of concepts of intersectionality more intuitively than academics do. And lastly, intersectionality is about more than just having multiple ways of understanding. It's also about addressing power imbalances. I'd say it's fundamentally about that. And attention to how we structure research can help to address some of those concerns. We do want to acknowledge our funders, especially want to acknowledge our research coordinators who've been working very hard on this project, as well as all of our other team members. Thank you.
Okay, thank you so much. All of the great amount of work you're trying to do to engage communities while better understanding what's happening on the ground. And it's clear that it's not an easy task. It's not business as usual when it comes to research. So we have lots of interesting material now to think about. We don't have a lot of time. And today's webinar was a bit of a trade-off. We had more speakers. We heard some about some great work and maybe not as much time to talk. But here's what I'd like to do. Let's start with that quote from Galliano. So history never really says goodbye. History says see you later. And so we've had a chance to reflect back on what's happened in the pandemic, and we can plan for the future now. And so it feels like addressing inequities during the pandemic moving forward and in future pandemics, it's going to require health promoters to counterbalance the focus on infection control. So what can we do moving forward? Let's think about maybe two areas with the time that we have. First of all, let's go back to this issue that I think Zoe and Kim highlighted, that there's advocacy that's needed, I think, in some ways. People in power are not hearing the issues that are very important, and so they're falling by the wayside, and it's being left a huge amount of burden on a very small workforce to pick up the pieces with a huge burden on their well-being. So what can we be doing to foster critical discussions about these topics now, so that the next time this happens, or even moving forward, policymakers get that it's not just about infection control? Is there a role for advocacy to the government? Is there a role for our training of future professionals, educators, people working in the field? What are some ways forward to make sure that we're not just left picking up pieces next time, but that we're actively dealing with the pandemic in a way that is consciously addressing the many communities at risk? Any ideas? I know that's a big question, but
I mean, I think when it comes to people who use drugs, there's so much evidence and research that it's actually not advocacy to then be implementing the things that people need for their survival. I think we debate so much about, about harm reduction, about and so much of the stuff that's come about through harm reduction has come about through activism and people doing things illegally and direct action instead of just being implemented by the healthcare system. And I think that it's a mistake on some levels that we've just, that we know that what the evidence is. I think also there's a bit of cowardice too from people who have positions of power to actually maybe do something that they feel might be uncomfortable or isn't something that the general public would be okay with. So for instance, when I met with Premier Kathleen Wynne with a group of doctors, I asked her, why wouldn't you call a public health emergency? And she said, because it wouldn't be politically viable. The general public would not be into it. Why wouldn't the general public be into it? It's a public health emergency. Why, and so I think that there's a lot of politics at play. And I think our job as health promoters is to be really clear, no, these are public health measures, or this is about people's health care. This is about people's rights to life. I don't know, but I think sometimes we end up having to do advocacy when we should just actually be implementing what we know works. And we really get caught up around advocacy, especially when it comes to harm reduction and people who use drugs.
So health promoters don't traditionally have a lot of power in the system, but we do have access to strategic decision makers, as you've highlighted. So who needs to hear this? Maybe it's not about trying to get the premier to rejig the whole approach, but who can we influence and talk to change service provision in a way that matters? Maybe that's a question we should all be thinking about.
I'm not sure if I'm answering your question, Keaton, but certainly when I hear the numbers that you're talking about, it is incredible. I think for me, I feel like I'm in the public health sector, but I had no idea the amount of death that you folks are dealing with. So I think one thing I can say from the climate change perspective, for us, it's kind of like we've got this slow motion crisis that's developing, that we're just going to wake up one day and we're find that we're in a planet that is no longer livable, and it's too late to do anything about it. So for us, it's trying to get people's attention about a problem that is kind of developing, whereas you're living in that crisis right now. I know in the climate change circles, what we've tried to do is just trying to bring other voices on. So last year when I was working at CAPE, we did a call to action on climate change and health, and we got 25 health organizations to sign on, just as a way of trying to bring the weight of others in our sector to bear. And I think for you, the advocacy there would be for them to take action, for them to implement the programs that we need. So I don't know if that would help at all, but I know for us, we're struggling with the same kind of thing. How do we get people to talk about these other issues when everybody's so focused on pandemic and the resources of the health and public health sectors are so focused on the pandemic? But certainly for us, we're struggling with that too.
Yeah, so I think storytelling to the right people who are implementing services, that the weight of what we're leaving behind, it's hard to ignore it, hopefully. We are almost out of time. I'm going to keep the discussion going, and if panelists can stick around and if attendees can stick around just for a few more minutes, the Zoom call is not going to end. And so let me just pivot to another question about research. I think from what Jen and Ahmed told us, it's critical to also be actively looking for where we need to be targeting more attention, and research is certainly one way to do that. But doing research during a pandemic proves there's all sorts of challenges, as Ahmed showed us. It's not so easy to do that. So I guess the question for me would be, you know, what are the ways that we can restructure research during these times? What are the things that research institutes need to be sort of mobilizing on so that communities can be engaged and we can allow research to translate into action?
So a couple things that come to my mind quickly is to have this learning health system approach. So really ask pragmatic questions that are meaningful for the people who we're trying to impact. And, you know, and this is probably my practical on the ground lens, but just try to do it as nimbly as possible so people can actually use the information you're producing quickly and to actually improve care. And I think also target some of the research. I mean, most of what I do is targeted for folks with barriers to care. Just so make sure you don't have sort of a general population lens. I mean, I think we need to highlight and really tease out some of these inequities, because if you always have sort of a general population lens, it's not going to be useful for all of the folks we've been talking about.
Thanks, Jen.
So, Keithan, I think in some ways it's the same answer to your previous question. I think if we truly want to talk about marginalization, and we want to talk about equities, and we want to talk about solutions, we need to, I think, rethink about how we structure the questions. So if you look at the questions that are coming from research funding agencies, they often reflect the agendas of governments or administrators, and they rarely reflect the agendas of communities. And if you look at even the types of methods that people are using, I'm not actually trained to do program evaluation. It's not, but you know, when the COVID pandemic hit, in the conversations that we were having, me and my colleagues, was, you know, how do we actually do something that's going to be helpful in this context in a short-term cycle? How do we use our skills to actually move a research agenda forward in a way that is going to have an impact? You know, it's not necessarily by applying to, I mean, I've done this as well, but but it's not necessarily by applying for the large research grants. There's an awful lot of research money that came out after COVID-19. But you know, I think it's much more about actually listening and radically listening to communities, to people who are experiencing marginalization, to like really understanding what's happening and thinking about the solutions that are being implemented in communities. And then the role of research then becomes not so much to even test those or show efficacy, but really to say, you know, how do we tell that story, and how do we think about the a structured way of saying what's working, what's not working. So those are the skills we have, and I think those are the skills that we can bring. But it would be a real shame if we reverted back to a real rigid sort of approach where we think we have answers that we are testing and imposing on communities, rather than listening to communities to tell us what the solutions are.
Yeah, thank you. And I think like Zoe's point was like, we need action, and in some ways there's no substitute for action. But I think one of the things I've noticed is that during the pandemic, it's a very evidence-driven affair. Everyone is very focused on evidence now. Even the public is so much more aware of like digesting data and using that to inform action. And so there is a role for research. And one of the things that happened well, I think, is a lot of funding came through for COVID-related research. But what I think I'm hearing you say, Ahmed, is that the calls were not focused on what needed to be focused on necessarily. And so it makes you wonder, when CIHR, when all of the funders came up with all of these COVID competitions, who set the agenda there? Did they talk to people at the community level to decide what the money should be going to, or what was in scope, what was out of scope? So maybe that's something way forward, is finding ways to convince the people holding the money, yes, for sure, let it go when we're in a time like this, let research happen to focus on this, but make sure you've already got a panel of people from communities who are helping you to define what these research competitions look like. Otherwise, we might just end up, like you said, perpetuating the government's agenda with whatever data we produce.
Yeah, I mean, for sure we need vaccine research, right? And you know, but if you look at all the money that went out for COVID-related research, an awful, you can go to the CIHR website and you can go down the list of people that got funded. And very many of those are not using an approach that builds from communities, right? It is very many of those are people who you may or may not have a few community partners, but you know, I think we just really need to think about not just from a funding perspective, but even from those of us who do research, really have to think about how we've traditionally done things, how we've been trained to do things, and really think about turning that upside down.
Right. Okay, well, I know that that was a limited discussion, but I do feel like we got a little bit more emergent knowledge there about action and about research. And I think that this is an issue that really needs a lot more attention moving forward. And so I hope that we can all kind of carry this conversation forward in our own shops and not forget about it, because the next time there's a big wave, the next time there's a pandemic, we're all going to be stuck in reaction mode. And as health promoters, I think we need to be the ones thinking first about the most marginalized and what's being left behind. So thank you so much to all of our speakers for sharing all of your insights today. You're all doing amazing work, and I wish you all well moving forward. I'd like to end by just quickly thanking the planning committee for this webinar series. These folks all came together on a volunteer basis, and we thought, you know, what could we do to help promoters do their work during this period? And we came up with the 4 webinars that we put on this November. And so I want to thank everyone on the planning committee for their hard work. And I want to give one last pitch to folks to learn more about Health Promotion Ontario. If you are working in the health promotion mode and you want to become a member, only $25 for students, $60 if you're not a student. And we hope to be able to offer more of these types of webinars while we're still in pandemic mode in the future. So sorry for keeping everyone a little bit late today. Take care, and I hope you enjoy the rest of your day.